down. So how you, if you cannot see, you can place your chairs on this side. So how you check for the cerebellar sign. Okay. So starting, first thing is the, as I mentioned, nystagmus. So you will be able to see the nystagmus directly. Okay, when you go closely, you may find rotatory movement or jerky movement of the eyeball. If you did not find, then you have to confirm. Okay, please follow my finger. Stabilization of the head is important because when you move sometime, the patient moves the head. So you are not interested in the head movement, you are looking at the eye movement for the nystagmus. Okay, so just ask, and what you will find is there is a cerebellar problem, there will be a rotatory movement, nystagmus, jerky movements. Okay, this is first cerebellar sign. Then speech. Okay, speech. So what type of speech you see in patient of cerebellar dysfunction? It is called scanning speech. Scanning. Have you seen anyone have seen a scanner? I think scanner, yes, in which you do.
Yeah.
What it does, the paper go stop, then again. So it is not a smooth like a photocopier. Yani it doesn't go and come out. So it take time here. So the paper scan in parts, step by step. Okay. So scanning speech is the same, that there are broken words. There are certain words which you have to ask the patient to say, and he will not be able to say that. For example, if the patient is an educated one, ask him to say constitution. So how many syllable? Constitution. So 4 syllable combined to make a word. This will not be possible due to lack of coordination if there is a cerebellar dysfunction. Patient will not be able to say the word like constitution. Okay, so how he will split? He will say constitution. Okay, so all these will be separately splitted. Another word for people who cannot speak English will say Constantinia. So again multiple syllables. Constantinia. Okay, so again the patient will be unable to say. There will be split. There will be a scan. Okay, so he will split all the syllables. Okay, so this is called scanning speech. So this is a sign of cerebellar dysfunction. So how many of the signs we have checked? We have checked the nystagmus. We have checked the scanning speech. Okay, now come to the upper limb. Okay, what are the signs you check for in the upper limb for cerebellar disease? Tone. So the tone in cerebellar disease will be reduced. Hypotonia. Okay, hypotonia. Again, ask the patient to relax. Okay, don't resist, and you can check it like this and compare it on the, because there could be problem on one side. You are checking on the other side and the problem is on the, so compare. Okay, right? Similarly here at the elbow level. Okay, another, you can do it, just relax, so this is again a way of checking the, so you just shake and like this and see if the patient has normal tone. So in cerebellar disease there will be hypotonia. Okay. Another sign which you check in a cerebellar disease in the upper limb is called dysdiadochokinesia. Name is difficult, but test is very easy. Okay, so this is another word you can ask the patient to say, and he will not be able to say it. Okay, so dysdiadochokinesia. So this is, the name is difficult, test is very easy. So what is dysdiadochokinesia? Ask the patient to do it like this. So alternate movement like this. Okay, if the patient have a cerebellar dysfunction, he will be unable to do this. Okay, this is called dysdiadochokinesia. Okay, I said that the name is difficult, but the test is very easy. So just do it on both sides to check if there is impaired coordination. Okay, so this is the fourth sign. Sequence can be up and down. Okay, so,
no problem.
So as long as you remember this, no problem. Then you check for the finger nose test. finger nose test. Okay, as the name indicates, so you will place, examiner will place the finger at a level. So this is the extended arm. So you have to place the finger at least at the level of the extended arm. Yani it should not be here, because then the patient may support and he can move. Okay, so it should be the unsupported arm. Okay, so you place your finger at a length of an extended arm. Okay, ask the patient to touch the tip of my finger. Specific command, not that touch my finger. Touch the tip of my finger and then touch your tip of the nose. Okay, so touch it, yes, and you keep on changing the target. So do it on one side and then do it on the other side. Okay, from the other hand. So this is called finger nose test. Okay, right? So you keep on changing and you see if the patient is having a normal coordination. This is a test of coordination. Okay, so this is called finger nose test. Okay, five. Okay, then you check for the tremors. What type of tremors you see in cerebellar disease? Intention tremors. Intention. Okay, intention. In Parkinsonism it is resting tremors. Okay, resting means that the patient is at the rest and there will be tremors. Okay, intention is that there is no tremor, but when the patient intend move, there is tremor. So how you check for that? There was a pen with me. This. Thank you. Okay. So what you ask the patient to hold the upper end of this pen. Okay, with your fingers like this. Okay, place it. So what will happen? Just for example, this is the target. So what will happen? Patient does not have any tremors. You will give him a target. Okay, with your hand or with your finger, grasp the upper end of this pen. So what will happen? No tremor. The moment the patient will go towards the target or intend or start moving, there will be tremor. So this is called intention tremors. Okay, and what else? The patient will be unable to reach that target. So either he will grasp it like this, he will not be able, because this is a highly coordinated act. So he will either grasp it like this, or he may go from right or from left. Okay, so this is a intention tremor. Intention tremor, when you intend, when you move. Okay, and the moment he will grasp, tremor will.
Doctor, who hold the pen? Me or him? Who hold the pen?
The examiner. The
Examiner,
examiner.
yes.
If you are examining, for example, I am the examiner for him.
Yes.
Okay, I'll give you a command. Please, with your fingers, hold the upper end of this. Okay, right? So this is normal. So what will happen if there is a problem or there is a cerebellar dysfunction? So no tremors at rest. The moment he will intend or start moving, there will be tremors, and he will hold it like this, or he may overshoot. He may go from right or left and he could not target that area. Okay, this is called intention tremors. Okay, so this is sixth sign. Okay, what next? Then you check for the rebound phenomena. Rebound phenomena. Okay, what is that rebound phenomena? Okay, so you place your hand, one hand like this or like this, and the other hand like this. Okay, and ask the patient to pull towards himself, yani here. So and you apply force that the patient does not. So you apply force downward and he is pulling toward, and suddenly what you will do, you will release the force. So normally what happens? Person will stop. If the patient have a cerebellar dysfunction, there will be no stoppage and the patient will come and hit your hand. This is important to place, because otherwise the patient may slap on his own face. Okay, so this is called rebound phenomena. Rebound phenomena. Okay, so you place your hand like this, apply pressure downward, and the patient will pull toward himself, and suddenly you release the pressure. Okay, and if there is cerebellar dysfunction, the patient will have no control over that movement and he will hit your hand. Okay, so this is called rebound phenomena. Okay, so this is the seventh sign. Okay, now so two signs on the face, 5 in the upper limb and 3 in the lower limb. Okay, now you can Yeah. So what are the things? Okay, one more thing which you can do in the same position in the lower limb is to check the knee reflex, knee jerk. Okay. I have shown you previously when we were doing the human examination that how to check the knee reflex. I flex it like this and I tap the hammer from below, patient having
Doctor,
this position.
this is examination when he lied or sit like
Which
Salah. This examination.
Knee reflex.
Huh? Knee reflex, I'm saying this is what I have done in the motor. So in motor you can do it like this. Now cerebellum I am just going to show you. So motor what we did, patient was lying, slightly flex knee from the like this, supported, and we tap and we see the. Now the type of knee reflex which we see in patients of cerebellar dysfunction is the pendular knee jerk. Pendular. What is pendulum? What is a pendulum? Pendulum. Haven't you seen clock tower? Makkah? There is a pendulum. Swing. Huh? So this reflex is also called pendular knee jerk. So what is the difference? The patient foot will not be planted. It will be slightly above the ground level. Okay, like this. And when you are checking the normal knee reflex, you are tapping it from below. Here you will tap it from above. Okay, so you will tap it above, and what will happen if there is a cerebellar dysfunction? There will be a continuous movement. Okay, pendular like. Okay, so this is called pendular knee reflex. Okay, pendular knee reflex. Okay, so this is the position to check the reflex, and if normally what happens, maybe after 1 or 2 or 3 times maximum, it will stop. But if there is a cerebellar dysfunction, it will continue maybe 10 times. Okay, this is called pendular knee reflex. Okay, now you can learn. So now we are done with the 8 signs. Huh?
Yes.
Okay. Now we are just left with the 2 signs in the lower limb. So these 2 are the one which are. So the same test which we do in the upper limb in the form of finger nose test. Here it is called heel shin test. Heel shin test. Okay. What is that? First of all, explain the patient. Okay, you have to do it like this. First of all, this is step 1. Yani one leg will be flexed. Place it on the shin, medial side of the knee. Okay, ideally this area has to be exposed if it is right. So place it like this. Then go like this and put it like this. So first explain the patient what you want. So this is basically a 4-step procedure or 4-step test. Step 1, flex. Step 2, put it on the shin. Step 3, go like this. And step 4, like this. Okay. So do it. Yes. Okay. So what will happen if the patient have a cerebellar dysfunction? He will not be able. So what will happen when he is going like this? He may fall. Okay, like this. Okay, and when he go till the end, he will not be able to put it like this. Even he may fall. Okay, so this means that there is a lack of coordination. Okay, so this is called heel shin test. It is the same or reciprocal to the finger nose test. Okay, same you check for the coordination. Okay, so this is the 9th sign of the cerebellar dysfunction. And lastly, you check for the gait. Okay, so gait. Okay, so what type of gait you see in patients of cerebellum? Waddling. What type of gait you see? What is the problem basically if there is a cerebellar dysfunction? What is the main issue? Coordination, ataxia. So ataxic gait. Okay, what is ataxic gait? Patient having difficulty in balancing. Okay,
Go
what
right.
will happen? He will tend to fall on the side in which the cerebellum is affected. So when he is moved, he may be having a broad base and he tend to fall on the side which is affected. Okay, so broad base gait and the side which is affected, he tend to fall. Now, how you differentiate a cerebellar ataxia? This is again a question maybe asked in the exam. Differentiate cerebellar ataxia from sensory ataxia. Okay, because both they tend to fall. So how you differentiate? Cerebellar ataxia, the patient will stand like this, okay, and he will fall, okay, on the affected. Right cerebellum is affected, he will fall on the right side. Left affected, he will fall on the left side. If the patient does not fall, fine, ask him to close the eyes. Now he is falling. So this means the patient is having a sensory ataxia. Now you have this sensory input is gone. So the moment you close the eyes, the patient will fall. So he can fall forward, he can fall backward, he can sway sidewards, okay? But in cerebellar dysfunction, generally the fall is on the affected side, not front or back, okay? So the affected side, the person will fall on the right or left, the side which is affected, okay? So this is called ataxic gait, okay? So if there is cerebellar dysfunction, you do it like this, eyes even open, the patient will fall, okay? And when he will move, he will also have a tendency having an ataxic gait and he may fall, okay? How you differentiate it from sensory? You just close the eyes. And if the patient initially who was not falling, now he is falling, so this means this is sensory ataxia, not cerebellar ataxia, okay? So these are the 10 cerebellar signs. I can tell you that in the exam, almost you can say 80 to 85% marks for this scenario of cerebellum is for these 10 tests, okay? Only 10% marks are for investigation and discussion. So which means that if you perform these tests already, so you will gain almost 85 to 90% of the mark without answering anything, okay? So this is important. That is why I have split it into these 10 signs which you must practice. And because as I said that majority of the exam, most of the time there is a scenario on the cerebellar signs, okay?
Doctor, it will be a station.
Huh?
It will be a station in the exam.
Yes, it will be.
And you ask about all the signs. 10 signs.
You will be asked to examine the relevant. I will not ask anything. I will
But there
see.
is no time
Huh?
for this 10. There is no time for this 10
It will
signs.
just take 2 minutes. If you practice, it will finish in 2 minutes. Not a big deal. 5 minutes is, this is what